Hello, I'm Petros Grivas. I'm a medical oncologist at Seattle Cancer Care Alliance and associate professor at the University of Washington and Fred Hutchinson Cancer Research Center. I'm very excited today to introduce our program, and I want to welcome for sure our audience in this very exciting session, which is about the impact of COVID-19 on cancer care and oncology in general. And this is a very important topic affecting all of us in terms of clinical practice, research, education, administration. And I think it's important even for trainees to think about those items and how the pandemic has really changed the way we deal with patient care and all the other aspects. I'm very excited today to be surrounded and discuss with two excellent colleagues, Dr. Cruz and Dr. Bhadkamkar. And I would like to let them introduce themselves. And Nicole?
Sure. I'm Nicole Cruz. I am currently a hematology and oncology attending at Weill Cornell Medicine in New York City. During the pandemic, when it started, I was actually a fellow here as well. So I went through that experience that I would like to share with you. When I'm not in the clinic, I do research in acute myeloid leukemia, mostly translational research.
Thank you, Nicole. And I think your transition can be very relevant to our discussion. Nishin, can you introduce yourself?
Sure. Thank you, Petros. I'm Nishin Bhadkamkar. I'm an associate professor in the Department of General Oncology at MD Anderson Cancer Center. I'm also the program director ad interim for the Hematology Oncology Fellowship Program. And my clinical practice spans the entire spectrum of solid tumors for the most part. And the majority of my time outside of the clinic is spent on fellowship program initiatives and education. And my research footprint is pretty small compared to a lot of my colleagues at MD Anderson.
Thank you, Nishin. It's very important to have voices and feedback from different institutions. So I think it's great to be able to discuss with both of you. Let's start the discussion here. I can tell you from my personal experience, I serve as the clinical director of the Gen 2 urinary cancers program at the University of Washington and Seattle Cancer Care Alliance. And for me, you know, the whole pandemic situation was a big, major teaching lesson. I learned so much about leadership, about, you know, administration, about making decisions under pressure. And obviously, you know, how agile and adjustable we have to be to deal with, you know, acute situations and crisis management. So I will start to, you know, by asking both of you, and Nicole, you can probably start by answering, in your opinion and in your institution, what was the initial effect of COVID-19 on cancer care back in March? And through your transition, how did you see that evolve over time? And how is the current state as this continuum, you know, evolves?
Right. That's a good question. It's I think my answer will be long, but I'll try to keep it short. So I remember the day of the official lockdown was March 13. I was in my last year of fellowship in my research rotation. And it was, I remember it was, the email said, all labs need to shut down immediately, like indefinitely. So we went through that, very strange. Same with patients, you know, we started calling our patients and telling them, we don't think it's safe for you to come. Let's try to remain in contact through telephones because video visits were not a thing then. And we only had patients that absolutely needed to be seen come in. I would say at first we felt pretty comfortable continuing the chemotherapy of patients that needed to be on chemotherapy. But as far as new patients went, we were perhaps more hesitant. And again, if it was needed, it was started. Immunotherapies, you know, if we could do with chemotherapy instead of immunotherapy, there's a lot of decisions that perhaps would not have been made in a non-pandemic situation were made at that time. I think, so that's the clinic side. I think the biggest change happened in the hospital. We really tried to keep our cancer patients away from the hospital. It was constant phone calls if they had a cough or they felt a little bit out of breath. We're like, in any other situation you should go, but let's try to manage this outpatient. Because we knew that once they arrived to the hospital, from what we were seeing back then, things could be pretty serious or bad for them. I think one of the hardest thing for me to see was that our ICUs became full very quickly. So one of the hardest things for me to see was that a lot of our cancer patients had to be made DNR, DNI, which means do not resuscitate, do not intubate. And that's a decision that perhaps in a non-pandemic situation, we wouldn't have done for many patients. So that's definitely something that was different during the pandemic. Rounds were also very different. Our hospital was very good at trying to protect the fellows. So only one person would go in, either the fellow or the attending. We even tried virtual visits. So I would go in with like a device that allowed my attending to see and hear what I was seeing on their phone. It was pretty cool. We tried that as well. It was a lot of learning, trying different things. And I think right now things have gone to a different normal, but they feel normal. Patients are screened before the visit, like with questions to make sure they're not sick. Once they are in the clinic, they all have masks, they are screened again, there's social distancing. I think now compared to when the pandemic started, everyone feels safer, but only because there's measures and a lot of care put into making everyone feel safer.
You touched upon very important several points, Nicole, and I was actually interested to hear about this device you mentioned, that you can wear the device and the visual picture can be transmitted to your colleagues or attendees. That actually seems very cool, and maybe in the future, we may have more of those, right?
Yeah, I think they were trying to use it later on to teach the medical students, because they actually were not allowed to be in the hospital, again, trying to protect them and the patients. So we thought it served its best purpose was in teaching the medical students so that they could see what we see, hear what we hear, and not miss the learning opportunity from an oncology rotation.
Absolutely. And the one take-home message, for the trainees who listen to us today is that, the need for agility and adjustability, right? You have to find ways very quickly, to maintain optimal patient care, at the same time, protect the patients, protect yourself, of course, protect your colleagues, the whole environment, and of course, innovation, right? Innovation and, removing barriers, right? Things that have been, in red tape for a long time, like telemedicine, we can talk about that in a second. You quickly find solutions that when there is a will, there is a way, sort of speaking, to remove those barriers. And obviously, one main priority, as you mentioned, was to try to keep patients who do not need to come away from the cancer center, away from the hospital, unless there is a need for them to come in. Nishin, any comments on your part about what about MD Anderson and Texas in general?
Well, I don't have anything technology related like Nicole. That technology, I guess, is still making its way to Texas. Hopefully soon sometime. But we certainly had, like Nicole said, we had to institute changes very rapidly in early March as the pandemic started. And the priority really was on protecting patients and also protecting healthcare providers. It became clear that having everybody in the clinic at the same time was a recipe for ultimately having many people get infected and then being out of commission for, the quarantine or the isolation period. And so I think the initial steps were about just reducing the volume of people that were in the clinic at any given time, and that included patients and providers. We certainly restricted patient numbers early on. We really thought hard about which patients needed to be seen in person and which patients could be addressed over the phone. Our video visits came online, I think, in early April. So it took us about a month to get that platform off the ground. And then the integration and the triaging of patients between in-person and telemedicine, that became a whole, part of clinic operations that we never really thought about or had to worry about before. And that actually became a relatively time-consuming task to look at each clinic and to say, okay, we have 25 patients today, or we have 25 patients planned for next week. Who can be done via video visit? Who needs to be seen in person? And I think we may talk more about this later, but I think the pandemic has really made us think very carefully about the incremental value of bringing a patient in for a clinic visit. A lot of the information that we use to make our decisions doesn't rely on a physical exam. We have our labs, we have our imaging, and a lot of the information we get from patients is just from asking them how they feel and about their side effects of therapy and disease-related side effects or disease-related symptoms. And so the pandemic really made us think, okay, who really needs to be seen? Who really has something where we can provide incremental value and where the benefits of that interaction outweigh the risks of exposing a patient to COVID. And so that became, I think, an interesting dynamic as we thought about how to triage patients. And then, over time, obviously our surge in Texas was quite a bit later, the initial surge, than it was in New York. And I think we actually had the benefit of being able to learn from the experience of the Northeast. And so I think we were a little bit better prepared and we had more time to marshal our resources and to get things ready for what we knew inevitably would be a surge of cases, and which in fact did happen in May and into June. So, I think that now we are pretty much back to our normal volumes overall. I will say that we still have a telemedicine component in our clinics, which varies from department to department. So for example, the GU Medical Oncology department overall, I think, has a relatively smaller telemedicine footprint, whereas some other departments have maintained a bigger telemedicine presence. And that's been very much on a department by department basis based on clinic structure, staffing, and those decisions are being made on a department level, not an institutional level now. But I think that we, as we sort of now are entering another surge, I think we've learned a lot of important lessons about how to adapt our clinical operations on the fly. And I think those lessons will serve us well because it's becoming clear that this is going to be a pandemic with many ups and downs, times when things are more quiet and seem more normal, punctuated by surges where we may have to make changes relatively quickly to protect our patients and our providers.
I totally agree. You raised really, really important points. And I have to tell you from my own experience in Seattle that this dynamic nature of the pandemic is really palpable with ups and lockdown. We really, started very early. Seattle was the first area, with the first case in the U.S. And, the command center, was formed immediately, almost overnight. And you have to come up with, principles, with some, values for our mission, and some, programmatic changes in order to adjust very, very quickly. And, obviously, as we went through the pandemic, things got, under some degree of control, with quote unquote, because, full control is very difficult to have during the pandemic. And then, we can, relax some of the, rules. At the same time, we have to keep some minimum rules in place, like screening all of the patients, as Nicole mentioned before. All the patients, in addition to being screened with questionnaires and surveys, they wear a mask in the clinic, and all the providers are wearing a mask. They practice social distancing, of course, hygiene measures, antiseptics, and of course, right now, in the last few months, we also wear face shields, all the providers, so to add some degree of protection, or goggles, because transmission can happen through the visual mucosa. In that context, you raised telemedicine and telehealth, as a new normal, which in my opinion is here to stay. Any comments, Nicole, on your practice, the proportion of patients that are being seen by telemedicine? And do you think that's going to change over time, or this is going to be, kind of a fixed, parameter going forward?
I think at least in at Cornell, they've allowed the providers to decide how they want their clinic to be based, whether they just want to see in-person visits, or both, or only televisits. I think so. At the beginning, to my surprise, a lot of my patients actually wanted to be seen in person. I did not expect that at all. Perhaps it's the bulk of my patients were older. So I'm not sure, and maybe it's a thing in New York City. Not everyone had like a daughter or a family member that could help them with the technology. And at first it wasn't easy, right? It was like, you have to download this app, and then you have to follow all these instructions. So I think that was probably a reason why at first most of my patients wanted to be seen in person. But then as the months progressed, this was around April, May, as the month progressed, I started seeing that for other providers, there were more video visits. Now as an attending, again, I do mostly research, so I only have half a day of clinic to half a day or 1 day. And I'm limiting myself to in-person visits. But if I wanted to do video visits, I could do that as well.
I agree. And, even in my practice, it has been a very dynamic thing that initially during March and April, I think the proportion of telemedicine visits was up to 50%. And then over time, it decreased. And right now it's probably between, 10, maybe 20%, depending on the clinic. I have two different practices. And it changes, of course, during the pandemic, and also in the phase of the patient's treatment, the cycle of treatment, active treatment, versus follow-up and surveillance, that you may have some wiggle room, and also the disease control status, right? Even if someone is on immunotherapy for a long time in complete response, you may have the luxury to postpone, some of the immunotherapy doses in this context of complete response, during a peak of the pandemic, versus someone who needs treatment right now, because of progressive cancer, which needs treatment, despite the crisis of the pandemic. Nishin, any comments on your part about telemedicine and how it has impacted your practice?
Sure. I think that, just to piggyback on what you and Nicole have said, I think the way that telemedicine is instituted is very much varies from place to place. I think, as I mentioned at MD Anderson, it's been very department specific in terms of how this is implemented. I also have much of my clinical time is actually spent at one of our county hospital affiliates, and there we've had a more measured approach to resuming in-person visits. So we for many months, we're doing 50% telemedicine, 50% in person at the county hospital. We just moved to increasing our in-person presence. So now it's maybe 70% in person and 30% telemedicine. But again, now we're starting to see cases pick up again in various parts of the country. And so it highlights that it's been very difficult to predict and to determine when the right time is to make changes. We had held off for a long time on increasing the in-person component because we wanted to be extra careful. We were probably more on the conservative side at the county hospital, given our patient population and some of their vulnerabilities. But now, as we move to more in-person visits, we're prepared to go back to more telemedicine in the coming weeks if we see that cases in the Houston area start to surge again. And I think this also highlights that even within a particular institution, at different locations, different patient populations, your strategies have to reflect the community and the patient population that you're serving. So just as an example, at the county hospital, we had started video visits and ran into a lot of issues with kind of unstable connections, patients who didn't have reliable Wi-Fi for their phones, didn't have reliable internet. And so it became clear that for many of those patients, the decision was really between a telephone visit or an in-person visit. And we started moving away from the video visits because it started taking so much time for the clinic staff to set this up and organize it and to make it work, that we realized that we needed to use our resources more efficiently. And patients, for them, it didn't really make a big difference to be on video. The ones who really needed to come in, we just would have them come in person. But again, it goes back to the question of really being thoughtful about who needs to come in and making sure that the people who have in-person visits truly have a strong rationale to need to come in. And I anticipate that this is going to continue to change and evolve with stops and starts and more telemedicine, less telemedicine. I think all of the things that you mentioned, Petros, in terms of precautions will continue for the foreseeable future. Everybody obviously wearing masks, patients coming into clinic with no family members, no other visitors to, again, reduce the numbers in the clinic. Obviously, masks and face shields are mandatory for us as well in patient care areas, or goggles. And so I anticipate that all of this is going to continue. And I think that I'm hoping that telemedicine will continue to play a role in clinical care once the pandemic is behind us, because I think we've learned a lot of important lessons about how this can be utilized effectively, not only for our existing patients, but to really expand the reach of our academic institutions. This isn't a new technology. It's been there for a long time, but we were also comfortable in the status quo that we never really employed telemedicine to its full capability. And I'm hoping that we can, in the future, use telemedicine to reduce some of the disparities in cancer care that we see, and that academic institutions could really take a leading role in helping to democratize the knowledge that we have and make sure that patients in rural areas and other kind of vulnerable patient populations have access to high quality care as well.
That's a very important point. And in the era of discussions, active discussion, I would say, about healthcare equity and equitable healthcare delivery, elimination of healthcare disparities it's very important to maintain important communication and ensure access to all those resources for vulnerable population, minorities, whichever type of minority you can think about. And it's very, very important, I think, as a community, as ASCO, as, policy of health in general, to keep those, disparities in mind and try to eliminate them in a significant way. I think it's you raised so many important points. One challenge that we find in clinic, as you mentioned, Nishin, is the time it takes, to room a patient in the Zoom call, right? Especially if they have some technical difficulties at home, poor signal, maybe more, senior patients may not have the capacity to have, savviness when it comes to internet, and, may not have a family member there. So that's an important, thing. And we try to have medical assistants, help with rooming the patient, but this can, impact the flow of a very busy clinic. To your point, how do you maintain the flow of the clinic and make sure patients that can be seen later are not waiting, right, because of a logistical technical issue? And I think we get better at it, but it takes, of course, effort and practice. The other barrier I think I have seen is licensing issues across states, and reimbursement, which is an important point for the hospitals. As patients, we just focus on patients. We want to see the patient and help them. That's our inherent, benevolent, humanistic nature. But there are also, these licensing and reimbursement issues, in the institutional level that can be barriers. And any comment you have on those things and about, licensing, and doing telemedicine in other states, for us has been a challenge. Any comments, Nicole?
So actually, at the beginning of the pandemic, it wasn't an issue. We were seeing patients from California, from like all across the United States through video visits. I think it's become a problem just recently. I saw a patient on Tuesday that told me that she had scheduled one video visit, like, I don't know, a month ago, and they canceled it a few days before because she lives in New Jersey. And that is apparently an issue with the license and all that stuff. So I think now that things are getting back to a new normal, we're starting to see these institutional barriers.
Any comment, Nishin, on that part?
No, I agree. I think the license issue has definitely come up. And because every state has different regulations, it's created, our legal department has been very busy in terms of sorting through all of the different state regulations and figuring out what providers need to do to be able to see patients from other states. And I think, Petros, the issue you raised about reimbursement is so critical, because I can see that being a major impediment to the maintenance of telemedicine post-pandemic, right? If in-person visits are reimbursed at a higher level than telemedicine visits for kind of equivalent complexity, then institutions are going to demand that we do in-person visits, right? And so I'm hoping that on a national level we figure this out. And make sure that we're not abandoning telemedicine purely because the reimbursement structure doesn't favor it. And I think that's going to be a critical issue.
I totally agree, and I think this takes an effort, on the advocacy and policy level. And again, ASCO has been very active in that regard, and I want to give a shout out to ASCO actually for doing all this work and all those programs that actually are aiming, to increase the ability to provide services to patients. Again, equitable healthcare, elimination of barriers, and I think in the federal and state level, advocacy is important. And actually, I had the honor to be part of this ASCO Leadership Development Program, and one of our projects is, advocacy and policy. So it's a very, very timely in terms of finding resources and trying to find ways that can enable providers and patients who work together in the middle of a pandemic. I will switch gears now a little bit to talk about education and learning, because we have trainees on the call. And I think it's important for all of us, to do our best to train the new generation, right? The people who can make it even better and find more cures for cancer. I think education is so important, mentoring and teaching. How has the pandemic impacted, the educational activities in your center? Maybe Nicole, you can start first, and then Nishin can comment on that.
Sure. So again, the shutdown or lockdown happened in March 13 here in New York City. And for the HEMONC fellows, what that meant was that all our didactics were canceled because you couldn't have more than a few people in a room. And it took us a while to figure out how to do this virtually. So I would say March, April, maybe mid-May, we didn't have didactic lectures, but we were encouraged to study for boards and keep learning any way we could. As far as patient care, right, because that's actually where most of our learning comes from, I don't think that changed much. It changed, but it didn't take away from our learning. Some of us were redeployed to different areas in the hospital, the emergency room, medicine teams. Most of us actually were either encouraged or told that we didn't have to show up to the hematology or oncology clinics if we didn't feel it was safe. So I think the learning was up to us, how much we felt safe in learning in person, right, from the patients. But for example, I was one of the fellows that was redeployed. And for me, that was a learning experience like no other. I'm really glad I did it. I'm really happy I was asked to do it. I felt it was an honor to be there. And I felt like my preparation as an oncologist helped me a lot with these difficult conversations that I needed to have. They change, right? Because the goals of care discussions you have with cancer patients are not the same conversations you were having with a COVID patient, like a 30-year-old that's healthy in the emergency room. That's not the same conversation you have with a 70-year-old that has stage 4 cancer. So that on its own is a learning experience for me that I would not have, in any other situation. So yes, the learning was impacted, but it was just a different learning experience, and we went through it. Difficult, but we went through it.
Totally agree. It's difficult, and we try to adjust again using Zoom calls or other, it's not only Zoom. There are many other, of course, vendors and venues you can do it online, and people have different preferences, and that's fine. But we use a lot of that ourselves, in terms of, teaching fellows. I recently did kind of a journal club with the fellows, through the virtual platform, and it went well, and people were engaged, and we try to figure out different ways to keep people engaged, because the attention span can be difficult
Yes.
to take, right, in a call like this. Nishin, any comments on your part about teaching and learning?
Sure. So, obviously in March, when the pandemic first sort of reared its head, the first changes that were made were in line with what Nicole outlined. Number one, we moved all of our didactics to a virtual platform. So at MD Anderson, our fellows have a half day for their didactic core curriculum on Tuesday mornings. And we immediately moved all of our educational sessions to the virtual platform. So that happened literally from 1 week to the next, when the institution put limits on the number of people who could be in a room together. So that was the very first change. And then along with that, we took fellows off of outpatient rotations in order to limit the number of people in the clinic and to allow for social distancing. And that was also the time when departments were trying to figure out how to triage patients, and there was a lot of uncertainty at that time. And so we took fellows off of outpatient rotations. Our inpatient rotations, which mostly were for heme malignancies, those pretty much continued the same. There weren't really many changes to those rotations, except that, you know, different precautions obviously were being taken, and, you know, COVID suspected patients were put in different units and those kinds of changes. But the inpatient experience for fellows was more or less the same. The outpatient experience in April and May was very different. And so we asked our rotation coordinators to sort of come up with a kind of a modified didactic curriculum for those rotations that could be done virtually. We asked fellows to participate in telemedicine visits with their attendings and to staff patients in that way and discuss cases over the phone. And then in June, we put fellows back on outpatient rotations, and that's continued now. The didactic program that we moved to the virtual platform has actually been going really, really well. I think that we're learning a lot about, again, how to optimally use the virtual platform for educational purposes. And again, we didn't think as much about it when we didn't need to, but now the pandemic has really forced us to reimagine how we can deliver hem-onc education given the current circumstances. And we're learning a lot about, you know, how to promote interactivity and engagement of learners. We've actually come up with some different, more innovative educational sessions that we were never doing before. I think there's been collaboration across institutions on didactics, which is something that is long overdue. And we actually had a discussion at the ASCO 2020 education program, which the people listening to this webinar can also reference, where fellowship program leadership talked about the impact of COVID-19 on fellowship programs. And so I think, again, there are a lot of important lessons that we will hopefully continue to take away and to implement moving forward. And I think that the other big effect that's been felt for trainees has been in two arenas. One is just a general sort of feeling of wellness and well-being. I think from program leadership, we've had to be very intentional about checking in on fellows, many of whom don't have family, you know, here in town in Houston. And so there's a sense of isolation that can set in because obviously, you know, you can't go out and hang out with other fellows. And so we've done a lot of Zoom events and other things to try to maintain social engagement among the fellows, and also with program leadership checking in regularly. And then there's been a major effect on the job search, which we can talk about also. I think the third-year fellows who are now looking for jobs, you know, it's a very different job market than any graduating fellows have ever faced. Institutions are, many of them are struggling a little bit financially in the midst of the pandemic. And so we've really tried to encourage our fellows to be a little bit flexible and adaptable, and understand that you may not be able to check off every box in terms of what you're looking for in a job this year. And you may have to be a little more willing than usual to be flexible, just given the constraints that institutions are facing.
Absolutely, very, very important points. Great discussion. I think this is really illustrating the different components of how we can try to be innovative, even in terms of education, learning, and try to learn from each other. As you mentioned, protect, the trainees, but also support them, right, in the job hunting process, as you mentioned. Be creative, in the interviews, and support them financially, if possible, emotionally, and also, giving them the resources they need to stay well. And wellness and resilience is part of survival, right? And I think during the pandemic, staying resilient and have compassion and kindness is important, and important to do it for yourself as well and to others. And I think all those components can be part of some, classes, part of some institutional trainee-driven opportunities and initiatives to support them during the pandemic. We have a few minutes left, and I would like to talk a little bit about research and clinical trials, translational research. I think, Nicole, you mentioned before that the lab had to close during the pandemic, and that's a very, very harsh reality. When you have experiments going on, you have to close the lab. It's an extremely painful experience, for those who are doing PhDs or postdocs or even in the lab. And on the clinical trial side, it's very difficult because clinical trials are a very important component of patient care. It's a standard approach in clinical practice, and we tried very hard at our institution at Seattle Cancer Care Alliance and University of Washington Fred Hutch to try to keep clinical trials open, and we had to individualize and select which trials are feasible to stay open and which had to close in terms of recruiting more patients, in terms of concerning new patients. Of course, with patients who are already on trial, we had to keep them going, of course. And I think we did a good job, individualizing and selecting carefully. Any brief comment? I would probably say a couple of minutes each one of you, if you can comment on the research angle, laboratory or clinical research. Nicole, you can go first.
Sure. Yes, research has definitely, and still actually, it's been impacted by COVID. Most institutions, so it varies by institution. Some, like MSKCC across the street from us, are open to full capacity. We're at 50% capacity in the lab, and others are even less. So some labs, for example, are working shifts from 6 a.m. to 2 p.m. and another one from 2 p.m. to 9 p.m. And I think I'm starting to hear from a lot of people that are doing that they're getting tired. This is not a normal workflow. And when you're learning, it's also difficult, right? Because you need the people that will teach you to be in the lab. So that's definitely affected learning for us trainees, and I'm sure medical students, MD, PhD students, postdocs that are ready to leave the lab actually have had to delay that for a year until all this settles down. And as far as clinical trials go, we tried really hard not to close any clinical trials. And like you said, to keep patients that were on trial on the trial. I think perhaps the biggest impact was in the time points, right? Like this patient needed to come day 21 for blood work, but you need to put patient safety first. So do I really need you to come for any other reason besides that blood sample? So I think that will affect clinical trials. But yeah, we really try to put patient safety at first.
Very important points. Nishin, any brief comment on that?
Yeah, I think initially we did have to put some constraints on clinical trials just because we needed to figure out how research coordinators could be involved without being on site, and we had to get all that infrastructure up and running. So there was a brief period where new patients weren't being enrolled on studies. But then once we figured out how to do this through virtual platforms, we were able to start all of that again. There was also a period, like Nicole said, where a lot of our labs that do the correlative work were closed. And so that did put a damper on some of the clinical trials. The only labs that were open during that time were the ones that were involved in doing kind of core facility operations. And so now all the labs are back. And so now we're basically back to 100% in terms of clinical trials. But again, I think we have to be prepared to make changes again if necessary as the pandemic unfolds.
Totally agree. And there are so many regulatory issues, budget issues in clinical trials, and the FDA tried to give some guidance. Definitely a huge, gigantic effort. A lot of great points by both of you. I'm really excited to discuss with you today. I would like to thank both of you, Nicole and Nishin, for very insightful comments that hopefully our audience will find very helpful. I want to also highlight that this is the first webinar in a series of virtual sessions for medical students and residents, and that this session recording will be available, as well as future sessions and other details in the ASCO social media platforms. So keep an eye for that. ASCO has a very active social media team. Also the My Connection medical students and resident community. And I would like to take the opportunity to thank ASCO for putting together this program. The ASCO staff work very hard behind the scenes. Of course, the audience who is the reason behind what we're doing. And my take-home message here is that, during the pandemic, you are going to learn a lot of things, and during a crisis, you're going to learn a lot of things. Stay open, keep the communication channels open, stay resilient, stay strong, and stay safe. Thank you so much for attending this program today.
Thank you.
Thank you.
Thank you, guys.